Primary bladder neck obstruction is defined as a failure of the bladder neck to open adequately during voiding. There are few estimates of incidence in females. These estimates come from studies of women who present for video urodynamics or with lower urinary tract symptoms. Incidence in those populations ranges from 4 to 8%. The etiology of primary bladder neck obstruction is still a subject of debate, though considered mechanisms include fibrous contractures, neurologic dysfunction, and abnormalities of the striated sphincter. Symptoms include hesitancy, intermittent stream, elevated post-void residual, frequency, urgency, urge incontinence, and in 15% of women, pelvic pain. Primary bladder neck obstruction is diagnosed with video urodynamics. Video urodynamics classically reveals a high-pressure, low-flow voiding pattern with evidence of obstruction at the bladder neck. This urodynamic tracing shows a classic patient with bladder neck obstruction. You can see she has no detrusor contractions during filling. When given permission to void, she has appropriate relaxation of the pelvic floor by EMG and a sustained detrusor contraction with off-the-scale pressures. Yet there is minimal uroflow. She has obstructed voiding. The question of the location of the obstruction is answered with the video portion of urodynamics. The scout film reveals clips in the pelvis from prior pelvic surgery and ensures that the patient is properly positioned. No abnormalities are apparent. The film at bladder capacity again shows no abnormalities. When given permission to void, voiding occurs as noted by the contrast emitted from the bladder, but there is no opening at the bladder neck, solidifying our diagnosis of primary bladder neck obstruction. Compare this to a film of a patient with normal voiding and you will see bladder neck funneling. Important to note also is that this patient has no urethral reflux, a potential long-term complication of primary bladder neck obstruction. Management options for primary bladder neck obstruction include watchful waiting, pharmacotherapy, and surgical intervention. Watchful waiting is an option for women with minimal symptoms and no evidence of adverse obstructive changes. Medications for the treatment of primary bladder neck obstruction focus on alpha blocker therapy. Documented rates of improvement in the few studies in females cite success rates from 50 to 66% in terms of decreased symptoms and post-void residual, as well as increased flow rate. Surgical intervention with incision or resection of the bladder neck can be very effective in women with success rates of 85 to 100%. Potential complications of surgery include stress urinary incontinence, vesicovaginal fistula, urethral stricture, and return of bladder neck obstruction. Surgical methods differ, using total excision of the bladder neck versus 1, 2, or 4 incisions at different locations around the bladder neck. The method you will see here is the 2 incision method with incisions located at 4 and 8 o'clock. Here you can see an initial survey of the bladder reveals trabeculations, commonly present in patients with obstructive voiding. Survey of the urethra reveals a high, annular bladder neck. This finding is sometimes present endoscopically, but not always. The resectoscope is placed into the bladder. The surgeon identifies the ureteral orifice on the left and on the right, and then turns her attention to the bladder neck. The surgeon again identifies the obstruction at the bladder neck. She makes one mock pass, and then proceeds to make her incision through the bladder neck at the 8 o'clock position with the right angle resectoscope cautery element. Serial incisions are made in the same line through the muscular bladder neck fibers at the 8 o'clock position. Throughout the surgery, the surgeon continues to identify the ureteral orifice to ensure that it is not damaged during surgery. She continues to make serial incisions at the 8 o'clock position. Again, the ureteral orifice is identified. And again. This process of identification of the ureteral orifice followed by incision of the bladder neck is continued until the surgeon feels that she has adequately opened the right side of the bladder neck. The surgeon assesses the bladder neck and urethra with the incision at the 8 o'clock position on the right side of the bladder neck. The bladder outlet is greatly improved, but still needs an incision on the opposite side to ensure adequate effect. The ureteral orifice is identified on the left side, and the surgeon returns to assess the bladder neck and the urethra. She then makes her incision at the 4 o'clock position through the stricture at the bladder neck. She again identifies the ureteral orifice and continues with her serial incisions. Again, she identifies the ureteral orifice and continues to incise the fibrous band at the 4 o'clock position. The surgeon then assesses the end result of her incisions at 8 and 4 o'clock. She then assures that there is hemostasis. The resultant bladder neck appears endoscopically open. The patient will keep a catheter overnight. She can return 4 to 6 weeks post-operatively for uroflowmetry and residual determination. This can be repeated in 6 and 12 months. Thank you for watching our video.